Hello, my name is Matthew Bakar, and together with Ellie Nuttall and Daniel Marcunas, we present to you the management of diabetic ketoacidosis in the setting of potential cardiac and neurological ischemia. HPI, a 61-year-old woman with a past medical history significant for hypertension, diabetes mellitus type 2, obstructive sleep apnea, and obesity, presented to the emergency department with aphasia and altered mental status. Per the patient's husband, the patient fell out of bed around 3 a.m., and he assisted her back to bed. She awoke at 4 a.m., called in sick to work, and returned to bed. She woke up that morning around 10 a.m. and was noted by the husband to be slurring her words. Her husband then called emergency medical services, who found the patient to be stuporous and noted that her insulin pump read 0 on the insulin reserve. On presentation to the ED, the patient was hypotensive, tachycardic, and tachypnic, and hypoxic, with an O2 sat of 85% on room air. On exam, the patient was obtunded with Kussmaul breathing. She received oxygen through a non-rebreather mask, and her oxygen saturation subsequently improved. Vital signs 96.5 degrees Fahrenheit, blood pressure 86/59, heart rate 131, respiratory rate 32. General, in acute distress, obese, ill appearing, toxic appearing, and diaphoretic. Cardiac, tachycardic, rhythm irregular, normal heart sounds, no murmur, no friction rub, no gallop. Pulmon, respiratory distress present, no stridor, no wheezing, rhonchi, or rales. Abdomen, abdomen is flat, bowel sounds are normal, no distension, abdomen is soft, no abdominal tenderness, no guarding. Extremities, right lower leg, edema, trace pitting present. Left lower leg, edema, trace pitting present. Skin, warm. Labs were drawn and significant results include glucose of 1542, CO2 of 5, anion gap 42, pH less than 6.82, beta hydroxybutyric acid greater than 60, lactic acid 10, high sensitivity troponin 2320, creatinine of 4.4. EKG findings: suspicious for inferior myocardial infarction and potential right ventricle involvement. Imaging findings: due to concern for stroke, CT head without contrast and CTA head and neck were ordered stat. CT head showed no acute bleed. CTA head and neck showed no occlusion or stenosis. Clinical course: at this time, a diagnosis of a high anion gap metabolic acidosis secondary to diabetic ketoacidosis was made. IV fluids and insulin drip were started. Electrolytes were closely monitored and replaced as needed. Cardiology was consulted and concluded that given her rising troponin and EKG findings that the patient potentially also suffered an NSTEMI. She was started on heparin, a high-intensity statin, and aspirin. Beta blockers were held due to hypotension requiring 2 vasopressors. Teleneurology was consulted and were concerned about an MCA stroke, given the patient's aphasia. However, the patient was out of the window period for alteplase and did not qualify for mechanical thrombectomy. Neurology recommended an MRI to look for ischemic changes. The patient was transferred to the ICU for continued treatment. With IV fluids and insulin drip, the patient's sugars slowly returned to normal range, and patient's altered mental status improved. Cardiology recommended outpatient ischemic workup, given that upon stabilization, the patient was not experiencing any chest pain, and her subsequent EKGs did not show any ischemic changes. Upon stabilization, the patient was discharged with recommendations for follow-up. Neurology believed the altered mental status and aphasia to be secondary to metabolic derangement from DKA, not stroke. Discussion: this case presents a complicated presentation of DKA involving multiple organ system dysfunction, all stemming from metabolic derangements. The complex workup of concomitant stroke, MI, and DKA can be overwhelming to any provider. In hindsight, the patient's accompanying symptoms were due to her metabolic derangement, but at initial presentation, these all required further workup. This emphasizes the need for problem management and prioritization. Thank you.